case, as you can really see, this is good biopsy. And we don't detect much of genomic abnormality or chromosomal growth abnormalities. Next slide. But we see a lot of mutations. The most important one is the BLM mutation, which is detected in the cell-free DNA, as shown on the top, at very high level, almost in the entire DNA, but it is heterozygous. So this patient, no question about it, has a mutation in the BLM genes as a germline. So this patient, the BLM gene is responsible for Bloom syndrome. And we detect additional mutation at very low levels, as shown here in yellow. When we compare the findings in the plasma with tissue, we detect, of course, these mutation in the tissues. And the things which I want to really point out is that if you look at the tissues, if we didn't do the plasma testing, the BLM gene mutation is detected at 19.1%, which if you look at it by itself, you cannot tell this is a germline abnormality, and we would have missed this if we didn't do the cell-free DNA. At the same time, what I want to point out that in the green, there's a mutation in PIK3CA that detected in the tissue at 11.83%, but this mutation wasn't detected in the cell-free DNA. Instead, a different mutation in PIK3CA, which is shown in yellow in the tissues, it was detected in the tissues at very low levels at 3.11%. That mutation detected in the peripheral blood cell-free DNA versus the one at 11% in the tissue wasn't detected in the peripheral blood. So this gives you some idea about the complexity when tumors really spill over their DNA into circulations. And there's a good possibility there are so many factors play a role here. Well, of course, the tumor heterogeneity is the most important part, but also it's quite possible that the clone that detected in the cell-free DNA has a mutation different from the less aggressive clone, and the less aggressive clone maybe not doesn't have higher turnover to pour its DNA into circulation. So it is very complex, and again, this goes back into my philosophy that always we should be doing testing on the cell-free DNA. We should be doing testing on the tissue. We shouldn't really accept one as replacement to the other by all means. And we should be doing the RNA on the tissue because the RNA provides a lot of information. Next slide. So this is actually show you the mutation in the cell-free versus in the tissue, and you can really see that we see a lot of artifact in the cell-free as well as we see a real mutation. Next slide. So this is in summary, and we think this patient most likely has a Bloom syndrome. I like really to see, to hear from Dr. Gutierrez about the history of this patient, but at the same time, there are multiple options from this study that can really, I hope, will help in terms of determining therapy for this particular patient. Dr. Gutierrez?
So actually, this is a fascinating case, and I don't know if this will have an impact on the results, but so this is a 57-year-old female who had a diagnosis of rectal cancer and happened to be a stage 4 disease. And most important, she has a history of cutaneous T-cell lymphoma in October 2017 that underwent an allogeneic bone marrow transplantation. So she's a post-allo bone marrow transplant with a new rectal cancer stage 4 disease. So from rectal cancer point of view, the two things that are very important for us in these results is the APC as a part of one of the original changes very early on in the oncogenic process of colon cancer. And the second thing that I can grasp up after is, as you pointed out on your in one of your bullets just before the last one, is the BRAF mutation, which clearly BRAF inhibition confer a subset of patients with colorectal cancer that actually could have a poor prognosis. And clearly, after they failed first or second line therapy, combination of EGFR and BRAF and MEK inhibitor is indicated. Those actually have confirmed response rates in the 30% on third line therapies. So clearly, that will be an option for the patient as well.
That's very interesting to look at theirs. So it is quite possible, based on what you just said, that the Bloom is, or the Bloom mutations, the transplanted
on the alum, yeah.
You know, which is very important. Really says that that's, you know, before any transplant, we should really pay attention and test these patients. That's
so actually, some of the BLM gene germline mutation are associated with, obviously, with some of the other cancers. So I guess the question will be, should we track down the donor?
Right, right. But clearly, this is a question to the transplanter you have to deal with on your hand. You know, so we should really discuss this with the transplanter, you know, and see how the bone marrow transplant taking.
Because it was very interesting what you pointed out. It was detected mainly in the liquid biopsy, but you would have missed it in the tissue.
Exactly right. Yeah.
Fascinating.
Yeah.